everybody for showing up to this evening's event of the Chemical Consultants Network. We are a topical group of the American Chemical Society Philadelphia section. Our mission is to help people start consulting businesses in the chemical sciences, as well as businesses that are affiliated with the chemical sciences. So we have people that are from pharma, from chemical companies like DuPont and Dow. We have people that are computational chemists, lots of life scientists, of executives, salespeople, a variety of different skill sets. Our object is to help those people start consulting businesses and help them prosper. And in addition, we also have an informal mission of helping people who are kind of in transition, maybe have left large chemical entities recently, and we try to help those people out as well. So during this Zoom call, we are asking you folks to keep yourself muted unless you're actually a speaker, like our speaker, Rick Pescatore. But at the end, you can ask questions, but you can also type in questions through the chat box. But in the meantime, everybody stay muted, please. And we're fortunate that our treasurer, Mr. Fred Hartman, has decided to host our speaker today, Dr. Rick Pescatore. And with that, I'm going to turn it over to Fred to do the introduction of Rick. Fred, it's all yours.
Hey there, everybody. First of all, as a Delaware resident, I am thrilled that we were able to get some help from Delaware health folks. I reached out to Carol Rattay, and Rick became, hey, I can help. An aerospace engineer out of the Naval Academy, figured that one out. Later became an emergency physician, chief resident at PCOM, Cooper's. More important, most recently, he is the head of the testing and clinical stuff that's going on here in Delaware regarding COVID, and is right in the heart of things. I reached out to him yesterday, and it turned out he disappeared because they have emerged into their emergency place somewhere in Smyrna, site undisclosed. We are thrilled. Rick, thanks for joining us. The question I put to you a month ago is, so we got a bunch of old people who are like very senior, very capable, very competent, and talking with people in consulting roles. And we're all like right in the crosshairs of COVID. What is the best way that we can interact with our clients?
Thank you so much, Fred, and thank you, Keith, and thank you all for being here. It's truly a pleasure to speak with you. And I'm going to talk a little bit about what's been going on mostly in Delaware, and on the whole, when we talk about COVID, I'm going to talk about the dynamic nature of some of our knowledge basis as it's evolved throughout the pandemic, talk about transmission, talk about testing, and talk about ways that we can keep ourselves and others around us safe. But sort of most significantly, I do want to leave time, of course, to just have a dialogue, understanding that the questions that are on your mind may be different than the questions that are on my mind. And I'm here just to engage in a Socratic dialogue more than anything. I always find that that's the best way to interact. So I'll share my screen here and go through a brief presentation. Please feel free to stop me at any time with any questions, concerns, objections, or whatever you may have. So let's see here. So you should be able to see my screen, and I'll just go ahead and start the presentation. So again, my name is Rick Pescatore. I work for the Delaware Division of Public Health, where I serve as Chief Physician and Associate State Medical Director, spending most of my time involved currently at the State Health Operations Center, organizing our testing response and examining the clinical side of our response to COVID-19. A little brief review of what's going on in Delaware: nearly 40,000 total cases and approaching 800 total lives lost. Our hospitalizations have peaked in the past several days, and we've seen a rise in the percentage of persons testing positive, as well as the percentage of tests that are positive, and we're nearing 600 new cases per day. We have tested nearly 500,000 people in the state of Delaware, and in just the past week, we've approached 60 to 70,000 tests performed in a single week, which truly has been a source of pride for us. As we look at the entire population of Delaware, we've been advised by HHS to pursue a testing target of 80,000 persons per month, and we have far surpassed that in our goal to take this graph here, the rate of positive cases, and pull it back into a more orderly and a more flatline approach. Perhaps what's most significant when we look at this graph here is we see rising cases not in the elderly population, which is what we saw in the spring, but we see rising cases in younger populations. And that's really a function of what we believe to be greater gatherings between persons of younger age and additionally college students. We have enacted a number of restrictions across the state, including limiting indoor gatherings and outdoor gatherings. We continue to have indoor dining open in the state of Delaware, but that is restricted to a significant degree. Indoor gatherings have been limited to 50 persons. Some updates on what's going on the vaccine in general is that we finally do see a light here at the end of the tunnel. We've seen an emergence of a number of therapeutics, and just today I was privileged to administer the first dose of a monoclonal antibody infusion on an outpatient basis in the state of Delaware. And that's one of very few therapeutics that have recently come to market and come to clinical practice in the treatment of COVID-19, both for inpatient and outpatient. But the light at the end of the tunnel, of course, was with the release of two vaccines, which have either recently received their EUA or are anticipated to receive their emergency use authorization in the coming days. That begins with the Pfizer vaccine, and that ends with the Moderna vaccine, both of which have demonstrated greater than 90% effectiveness in the manufacturer's clinical trials. And certainly that's reassuring, and that's something that we're planning very significantly for as we move forward in the coming days to weeks. We do anticipate that we will begin phase 1 rollout of our vaccine in the coming days here. We anticipate that December 11th is when the first vaccine will hit our shores here in Delaware, and we will immediately reflex that vaccine into our prioritization groups. We look at those prioritization groups not as a category that you must belong to receive the vaccine, but really prioritization groups to where the vaccine will be distributed, and understanding that there will be an overlap and a mixture of those prioritization groups. We talk about phase 1A, we talk about phase 1B, and individuals such as yourselves, critical infrastructure workers who are working in a high-risk setting, and many of you I heard mention are either approaching or greater than the age of 65 years old, would fall very quickly into our phase 1B of their anticipated tiered allocation group. And what does that look like? So as we talk about, it's not an immediate assignment and we're going to finish everybody in phase 1A before we move on to phase 1B or phase 1C, but in fact, a rolling allocation of vaccine as it comes out. And it's very likely that those in phase 1C will begin to receive the vaccine in just a few weeks here. And that is, again, very reassuring, very exciting, and something that is a light at the end of the tunnel when we talk about COVID-19, how it affects our entire population, how it affects yourselves, particularly when you may venture out into public, interact with others, and put yourselves at risk for contracting COVID-19 in your duties as consultants or as chemical engineers. Again, another example here is how we anticipate the rollout of the vaccine is that we anticipate that those in phase 1B and phase 1C could begin to receive the vaccine as early as the end of this month. And that's very exciting and something we anticipate should happen quite easily. So I do want to talk a little bit about testing in the state of Delaware. I know not everybody on this call is here within the state of Delaware, but we have worked very hard to make testing extremely accessible across the state. We begin that with our fixed testing infrastructure at our state service centers, our DPH clinics, and Walgreens. These are centers that are there 24/7 and available to persons to get tested, and they always know that they can go there and get a test. Additionally, we have our semi-permanent and our community pop-up sites, which continue to function throughout the state. Testing is free of charge throughout the state of Delaware. It is performed under my order as the state chief physician, so an additional order from a physician is not required, and there is no charge whatsoever. Our turnaround time remains around 42 hours on average, and we look forward to continuing to broaden that access and ensure that more and more people are able to gain access to easily accessible and fast turnaround testing. We also have what I think is a particularly exciting option, especially for those Delawareans over the age of 60, and that's anybody who lives or works in the state of Delaware and belongs to any of these priority groups. That would be teachers and staff and students of Delaware schools, any individuals who recently attended a large gathering, or perhaps most significantly, Delawareans over the age of 60 can simply go to de.gov/home test and obtain a home testing kit. It's mailed directly to your house. You perform a Zoom chat with a medical professional just like this actually. It's a saliva-based test. You spit into a tube, place it into a UPS mailer, which is again provided free of charge, and results are transmitted electronically 48 to 72 hours after performance of that test. Another, I think, interesting and really fantastic option for testing within the state. But what is this all about, and what is really the key that we're here to talk about? We're here to talk about transmission of COVID-19. Now, I can remember at the beginning of this pandemic in late February, early March, we were operating on a very limited set of data that had emerged from China and Italy, and a very small cohort of patients that had been studied on the western coast of the United States. When we looked at that, it was full with misinformation and disinformation and confusion about how the virus was transmitted. And that's been sort of expounded over the course, where we've seen production of both articles in the lay and scientific press that have confused different mechanisms and methods of transmission and sort of stirred a little bit of fear and misinformation about the virus. I've said it once, I've said it 1,000 times, that often the confusion and misinformation that surround the virus are just as dangerous as the virus itself, and it's contingent upon individuals like myself and those I work with, as well as scientifically literate people like yourself, to spread the gospel of the truth and the evidence that surrounds COVID-19. And what do we know now about COVID-19 is that the overwhelming majority of infections are through droplet transmission, that is close contact transmission within 6 feet for greater than or equal to 15 minutes, provides enough time for a large enough bolus of infectious particles to travel from one individual to another. And we say it again and again, it becomes almost hackneyed, but now where we repeat the 6 feet, 15 minutes moniker again and again, understanding that close contact transmission, that is droplet transmission from one individual to another, is what is required overwhelmingly to transmit the virus. We should talk a little bit about surface transmission and aerosolizing transmission because they've come up so much in the lay and scientific press over the past several months. Surface transmission, that is contact, is when droplets can land on surfaces and objects and can be transferred by touch. Early on in the pandemic, this made the rounds as you have to leave your groceries outside for a day or two so that any infectious viral particles could die. This made the rounds after a paper was published in the New England Journal of Medicine that looked at survival of viral RNA on surfaces and recognized that it could survive for hours to days on surfaces and still be detected by RT-PCR. Now, we've learned over time, however, that this is, if anything, one of the least likely ways that COVID can be transmitted. COVID dies quite rapidly when exposed to the air, and COVID dies quite rapidly when exposed to ultraviolet light. And all of those are around us every single day and rapidly inactivate viral particles. And while COVID can be detected by our molecular testing methods, that is RT-PCR, that COVID is not infectious. And often they will have threshold cycle times far greater than the number 30, far greater than the number 40, far greater than the number that would be typically seen as infectious particles on a surface. So while we continue to recommend that hand washing and cleaning of surfaces take place, we've learned over the past several months that there is no deep cleaning or special cleaning that is necessary to kill COVID. There is no special protocol that is needed to ensure that contact transmission is mitigated. We've learned that surface and contact transmission is perhaps one of the least likely routes of transmission of COVID-19. But perhaps the sort of boogeyman of transmission of COVID-19, perhaps the one that is talked about the most and feared the most, is this talk of aerosolizing transmission of COVID. And there is indeed a growing body of evidence that these droplets from close contact and airborne particles can remain suspended in the air for quite some time, minutes to even hours. And beyond that, travel distances beyond the 6 feet that we most often talk about when we talk about close contact transmission. And this has been documented most specifically in confined places with minimal ventilation or ventilation far below standards. Now, what is the difference between aerosolizing and droplet transmission? Well, it all exists on a continuum. And I think one of the most important points that we can talk about is that there is not a simple dichotomy between what is a droplet transmission and what is an aerosolizing transmission. And if somebody coughs or sneezes, it is quite reasonable to suspect not something as an aerosol, but in fact, a small particle aerosolizing transmission, a suspension of droplets in the air that could be infectious for a longer time and at a longer distance than within 6 feet for greater than or equal to 15 minutes. And that does begin to influence many of our recommendations of how we can keep ourselves and keep others safe. So what does that mean? There are many ways that we can talk about personal protection. And one of the things that we talk about all the time, of course, is the role of face coverings. Now, face coverings come in many shapes, sizes, and varieties. And there is a fundamental difference between cloth masks versus medical face masks. Now, if you are coming into contact with an individual with known COVID-19, CDC and DPH recommendations currently recommend the use of an N95 mask, and that prevents the transmission of aerosolized particles from one individual to another. For individuals who are not known to be infected with COVID-19, however, the use of a medical face mask, a surgical grade or medical grade face mask, is highly recommended and a baseline level of personal protective equipment that can keep you safe from transmission from others. Over the past several weeks and months, there's been a lot of talk about the use of cloth face covering, and there is a growing body of literature that cloth face coverings prevent transmission between individuals. We have for a very long time made statements that my cloth mask protects you from me and doesn't necessarily protect me. Latest evidence actually beats back on that a little bit and actually suggests that the use of cloth face coverings also arrives at some degree of protection for the wearer. And in fact, there's some postulation that the use of a cloth face covering may lead to attenuated transmission of the virus and a lower viral load that would be taken on by somebody if they were in close contact with an individual for greater than or equal to 15 minutes. So while medical face masks do provide the greatest amount of protection in everyday interaction with other individuals, even a cloth face mask has been recently demonstrated to attenuate transmission of the virus, decrease the viral load that an individual may suffer, and protect the individual from others. Now, what would I recommend? I'd recommend that you individuals, if you were interacting with others, if you have the ability to interact with a medical face mask, that does raise your level of comfort, raise your level of safety, and would be my recommendation, particularly if there's any risk that you could come into contact with an individual who is not wearing a face mask. And particularly if you were likely to find yourself in an area where social distancing, that is that 6 foot distancing, could not be maintained. We talk about hand hygiene. And why do we talk about hand hygiene? Of course, because of the possibility of contact or surface transmission, and because hand hygiene is always a good practice. But perhaps the most important thing to talk about, perhaps the most important thing to highlight, is the importance of social distancing, maintaining greater than 6 feet between individuals. Time and again, we've looked at the distance that would require to keep individuals safe, and the World Health Organization has recommended at least 1 meter, 3 feet of separation between individuals, recognizing that that amount of distancing between individuals has the ability to cut transmission by at least 50%. And that's pretty exciting and pretty profound. And we know that if we increase that distance to 2 meters, 6 feet, that it decreases the possibility of transmission even further, perhaps up to 80 or 90%. And that's when we're talking indoors and we're talking without the use of face coverings. When face coverings are combined with social distancing, it's a synergistic effect in preventing the transmission of COVID-19. And then beyond that, and perhaps the greatest recommendation that we can make, is that the combination of face coverings with social distancing and a well-ventilated area or even interacting in the outdoors is perhaps the greatest level of protection that you can have. When we talk about consulting, when we talk about interacting with others, What we can do that to the greatest extent to protect ourselves would be to combine all three of these, understanding that each of them has a large effort and a large contribution to stopping the spread of COVID-19 and attenuating transmission between individuals. We talk so much about how COVID can be transmitted, and we don't talk too much about what we can do to protect ourselves. There are so many things that we can do to protect ourselves, and they seem at times simple. It seems simple to simply wear a mask, keep distance from others, and wash our hands. But too often we find that that is not carried out. We find that individuals surrounding us may not be wearing a mask. Individuals surrounding us may not respect the social distancing. And because of that, by layering these protective options on top of each other, we can have a safer approach to everything that we may do. That is the extent of what I have to present to you. And I want to open the forum up just to have a conversation about what questions I may be able to answer, what questions may be on your mind, maybe you've heard from social media, from friends or family. And if you have any questions or things you'd like to discuss, please, let's bring it up and have a conversation about it.
Yeah, the floor is open. Anybody who wants to ask a question of Rick, just unmute yourself and go ahead and ask.
I've got a question.
Yes, sir.
Yes, I've heard that for the 1B, in other words, people over 65, there's actually a 1B1 and a 1B2. And the 1B2 is for guys like me who got COVID early in the game and recovered, and in principle have some degree of immunity. Is that correct?
That's a fantastic question. Now, CDC has actually come out specifically and spoken against using previous infection as a gradation for when an individual would receive the vaccine. And while there is a 1B1, a 1B2, and in fact a 1B3, the previous infection does not currently weigh into that. Now, that is to say, that is the recommendations through the ACIP and how these vaccines will be distributed to organizations that are giving out the vaccine. For example, we will distribute large amounts of vaccine to a hospital, for example. Hospitals will have the ability to make their own gradations and their own assignments of which individuals within their institution will receive the vaccine. Most hospitals, most organizations will make those decisions via ethics committees and ethics boards, but the current recommendation is not to use previous infection or evidence of previous serological immunity to dictate whether an individual should receive vaccination.
Very good. Thank you.
Thank you.
Do you have any comments about the risks associated with air travel?
I'm happy to comment on air travel. So early on in the pandemic, air travel was actually considered it was a moderate risk contributor to contracting COVID-19, and air travel with any individual on the plane who ultimately was diagnosed with COVID-19 immediately placed an individual into a medium risk, a moderate risk category for contracting COVID. Since then, there's been a number of studies, and in fact, about 3 weeks ago, CDC released a study looking at air travel and found a lower risk because of the fantastic air filtration systems that are present on today's commercial airliners, and because of the masking policies that are being enforced on commercial airliners. So while I do believe that it's likely that in an enclosed space, the risk is of course raised to some degree, it does appear from the data that we now have that the combination of masking and the air recycling and filtration systems that exist on commercial airliners are enough to mitigate that risk. So my recommendation is consistent with the CDC's recommendation, which is to say that if you are traveling by air, the use of a medical grade face mask can provide you that extra level of protection and ensure that your level of risk does not raise above the baseline level of risk.
Thank you.
Thank you.
Rick, I'm in a different state, and I'm wondering how much of this information applies only to Delaware and how much of it is nationwide or regional.
That's a great question. So much of the testing is Delaware specific, but when we talk about immunization, what you're seeing here on the slide right here, ACIP recommendations, this is a national level recommendation for distribution of the vaccine. Now, states can and will make alterations to this. And in fact, here in Delaware, we are going to make alterations to this. And we believe, for example, that adults with high-risk medical conditions and adults 65 years of age and greater belong in phase 1B. And we have actually moved these individuals into phase 1B here in Delaware. What we're looking at here is the national recommendations, which can be altered at the state level.
Thank you. I have a follow-up if that's okay.
Please, please.
You mentioned the testing and I've seen some interviews and I've read some things about the number of cycles on a PCR test, and the higher number of cycles, the less chance that you're actually a positive COVID case. That confuses me. And also I wonder, like, if I am tested, how do I find out how many cycles were used?
Great
And
question.
will I count as a case even if, like, let's say my cycles were above 35 or whatever the number is, would I still be counted as a positive case?
That's a great question. So I'm going to answer your second and third question first, which is to say you will not find out your CT value, your threshold cycle value, and you will be counted as a case no matter what your CT value was if it was positive. And let's talk a little bit about that. So PCR, or polymerase chain reaction, is molecular testing. And it is quite simply where respiratory, and I apologize if this is simplified for anybody, but I'm a simple ER doc, so I make it simple for myself, which is to say a respiratory specimen is collected. It's lysed in preparation for RT-PCR, and then PCR amplifies that signal again and again and again, doubles it, doubles it, doubles it, doubles it. And the number of cycles that it takes to double it until it reaches a predefined threshold of positivity is called the threshold cycle, or the CT value. The greater that CT value is, the greater number of cycles it took to reach that predefined threshold of positivity. So if you have a CT value of 15, you have much more virus than if you have a CT value, for example, of 30. Recent both lay and scientific press articles have argued that those individuals with CT values over a certain number, likely 30, perhaps as low as 24, are simply non-infectious virus and should not be considered positive cases. Unfortunately, a lot of those data are based on some kind of weak studies. And the number one study that's cited overall as the harbinger of why we should not be using these tests anymore actually combined high CT values with a duration of greater than 8 days since symptoms had started. So it's a little disingenuous to only apply the CT value instead of also taking the time-based approach to clearance from isolation. So to put all that to the side, it doesn't matter. And the reason I say that is there are no current PCR tests that are approved by the FDA for quantitative detection of SARS-CoV-2 virus. All PCRs are only licensed for qualitative detection. And because of that, it is in fact outside of the emergency use authorization to provide that CT value. It's not illegal, but it's unlawful and not consistent with the emergency use authorization. And because of that, the CT values cannot be released except in very specific and narrow context, which basically is me walking over to the lab, pulling the CT values, and in the context of me doing either a validation study or some other scientific pursuit. So those CT values won't be released, but we should talk a little bit about that. So it's absolutely correct that there are many individuals who test positive but are in fact not infectious in any way, shape, or form. And we have seen, as we've progressed through the pandemic, greater amounts of people who have high CT value tests, and they're positive, but they're not really infectious. And this has been really behind a number of things. First is that we've moved away from a test-based clearance method. Once you're positive, you're generally considered that you will be positive for about 3 months. And in fact, the CDC recommends against repeat testing in the 3 months, the 90 days following your first positive diagnostic test. That's important. They say that if you have a positive test within the 3 months after your first test, it doesn't mean anything. It's just residual viral RNA, and it's not reinfection. They've also used that to drive their recommendations for their clearance from positivity. Once you're positive, we no longer use a test-based clearance mechanism. Early in the pandemic, that you needed 2 negative back-to-back PCRs to say that you were no longer infectious. The current recommendation is simply 10 days following your first positive diagnostic test or 10 days following your first day of symptoms, you are considered no longer infectious and you can go about your merry way and into the world. And then the last thing that this drives is a large push, both in the scientific community as well as in the general public, toward a greater use of antigen testing. Now, we're all familiar with antigen testing. We've all been to our primary care doctor or an urgent care or an ER and gotten a rapid strep test or a rapid flu test. And those are antigen tests. And they look very much like a pregnancy test. They look very much like any other test that you can buy off the counter in your local Walgreens or CVS, a rapid strep test. And those look for, quite obviously, the antigen, a whole piece of the virus, and is more likely to reflect a person who has active and infectious virus. Now, so what we will see and what we have seen is in the past few weeks, and really just the past week or so, a greater push for the utilization of antigen testing. This is the BD Veritor, the Quidel Sofia, and the Abbott Binax Now point of care antigen tests, all of which have immediate turnaround, which is very nice and a very logistically friendly mechanism to contribute to testing. And they're probably more reflective of individuals who are truly infectious.
So Rick, following up on this theme, have you've heard of Jennifer Doudna?
I haven't.
Okay, she just won, or she's won the Nobel Prize with another lady from France for the Nobel Prize in Chemistry, and she worked on a gene editing or genome editing technology called CRISPR that you probably heard of.
Yes, sir.
Yeah. Well, at any rate, Jennifer is at University of California, Berkeley. She and her lab have been working on a test for COVID that can be performed in 5 minutes. And you may find it very interesting. It's not as sensitive as PCR, but it is actually quantitative or semi-quantitative for viral, infectious viral particles. So
Sherlock CRISPR assay?
It's probably based on CRISPR technology, and right now it's not very sensitive. It's not as sensitive as PCR, but I'm sure she's working on it. And was wondering if you could comment. I was thinking if a physician like yourself and other people could have a test that was fairly quantitative for viral particles, what you could do to match symptoms with viral load and things like that. Do you want to comment on that?
Oh, absolutely. I think that that is incredibly powerful. And so often we talk about sensitivity and specificity of these tests when more often we should be talking about negative and positive predictive values, synthesizing that clinical picture with the analytical performance of the test. And I certainly would agree with you that physicians, it's incumbent upon physicians to take scenarios just like that and use the pre and post test probability of the tests that they're implementing and combine it with the clinical picture. And it's something that we do routinely in other parts of our clinical practice, and something that has been all too blatantly missing from testing for COVID. So it does sound something that's particularly exciting and could gain a lot of traction in the clinical environment.
And apparently it can be done in 5-minute time span, something like that.
That would be tremendous and just an absolutely fantastic contributor to getting this bull around, the lasso around this bull.
It is not FDA registered yet, but I'm sure they're working on it.
Soon, hopefully.
Mm-hmm. Are there other questions from the floor?
Yes, the rumor has it that the do-it-yourself mail-in tests are less accurate than the tests done at a testing facility. Do you have any comment on that?
I would like to push back on that rumor. We do, in fact, have, at this point, a reasonable body of evidence that patient self-collection of anterior urinary samples or saliva samples has a comparable positive and negative predictive value when compared to clinician-collected nasopharyngeal samples. But perhaps most importantly, and putting my public health hat on now, we have found that there is much greater uptake in patient self-collection of samples than there is in clinician-collected samples because of the sort of pain and fear associated with clinician self-collection. And so we have reached a point where we've decided, and the data would support this, that if there is a minimal decrease in analytical performance of patient self-collection, it is likely that the uptake in that testing mechanism far outweighs any analytical drawbacks. And then to sort of hop on that a little bit further, we do have the ability to ensure that the sample was collected appropriately. So when we talk about those CT values apply to both the N1 and N2 proteins, right? We look at both the nucleocapsid 1 and 2 proteins. We also look at human ribonuclease protein. And we do that to ensure that there's enough human detritus on that sample to ensure that there was a proper sample that was taken. And so while we don't typically act upon those numbers, we do monitor them to ensure that the sample was appropriately collected and is sufficient to be labeled a adequately collected sample.
Thank you.
Thank you.
Other questions?
Yeah, I'd like to talk about masks. Going back to masks, you said medical masks are the best. What about homemade cloth masks?
Yeah, so great question. So really the best mask, of course, would be the N95, medical masks outweighing homemade cloth face masks. And for a very long time, we've thought of cloth face masks as simply preventing transmission from one individual to another, and the cloth face mask was a protection for other individuals. But in just the past week or so, CDC has released additional data that it does appear that cloth face masks offer some protection to the wearer as well. It does appear to be minimal protection and not profoundly significant protection, but it does appear to likely attenuate transmission to the degree that if you come into contact with an individual and are and contract the virus, it is likely that you will have a milder course because of the lower viral load. There aren't many viruses for which viral load at time of contracting makes much difference. However, it does appear that it does matter for COVID-19, just as it did, fascinatingly, for the influenza virus of 1918. It is one thing that both of these viruses have in common, and one of these things that both of these viruses differ from most other respiratory viruses in that regard. So while I do recommend medical masks for protection of yourself, should you find yourself in a scenario where risk is elevated above baseline, that would be coming into close contact with individuals or finding yourself in an enclosed and poorly ventilated space, even cloth face masks do appear to add some degree of safety.
Thank you.
Just to clarify your point on viral load, Rick, are you saying that you believe that the more viral particles you pick up, the likelihood of suffering severe COVID is increased?
Yes, sir. It does appear that's the case. It's something that I beat back on early on in the pandemic because it's not the case with the overwhelming majority of respiratory viruses. But since the early pandemic, we've had a growing data set that suggests that the amount of viral load that you suffer at time of contraction does correlate with severity of symptoms. And that seems to be perhaps one of the reasons why healthcare workers have had worse outcomes than their case-matched general public.
Rick?
Yes, sir.
I heard a piece the other day that the 1917, 1918 virus mutated such that 18 was like really lethal, did about a 6-week term in each place it hit, had a much higher kill rate. Do we have any sense of how the lethality of what's out there is and over time is doing?
We have both anecdote and data in that space. So let's talk first about the data. We here in Delaware and across the country participate in the genome sequencing project, and we do genomic sequencing of the virus and we publish it alongside laboratories across the country. And it's been interesting to see that there has been progressive mutation of the virus throughout the pandemic. Now, we have yet to have a data-driven conclusion as to what that means for the virus's lethality. And here's where I'm going to move into my world of anecdote. Early on in the pandemic, I spent much of March and April in New York City and northern New Jersey, working in ICUs in the sort of epicenter of the pandemic.
Thank you.
And I watched things I never would ever have thought I would see. Just entire hospitals turned into ventilator wards, waiting rooms turned into, you know, what it looked like was, we've all seen the pictures of the rows and rows of iron lungs. And that's, I'll tell you what it looked like in March and April when I was working in North Jersey and New York.
You were there.
I was there.
Yeah.
And that's not what it is right now. I work in the emergency department as well as for the state, and I spend my nights and weekends in the emergency department. And anecdotally, the lethality seems to have gone down when I compare it to my experience in March and April.
Rick, Peter Bernstein here. Would this dose and the link to severity, that's a very interesting finding. There's the recent finding with the AstraZeneca vaccine, that where they accidentally gave a lower loading dose, that it appears to be much more effective. Could that tie, in my mind, that's sort of tying in there that there's something about this virus where when the immune system sees it, the level of insult seems to be playing a very significant role in what's going on in the body later on. And I'm wondering if you know if anybody has tied those 2 points together.
Yeah, I couldn't agree more. And so 2 points there. One is there is some data to suggest that individuals with less severe clinical course have a less profound immune response. And that is both the reason for their less profound clinical picture, as well as it leads to a less vigorous immune response. But then when we talk about the AstraZeneca vaccine, it does seem likely to have some nuance to it. The AstraZeneca vaccine, as I'm sure you know, is an adenovirus-based vaccine, an adenovirus vector. And one has to wonder if the adenovirus vector plays into the immune response. All of us have adenovirus antibodies circulating throughout our system. And one has to wonder that if there's a lower dose of adenovirus that's with, of course, a spike protein mutation that's introduced into the body, does our adenovirus response facilitate uptake of a new T-cell mediated response to that spike protein that's been added to the adenovirus? I don't know. It's exciting. I personally, if I had to choose a vaccine to take today, I would choose the AstraZeneca adenovirus vaccine. But I agree with you.
I mean, at the standard dose, it's perhaps 60% effective, and the RNA virus vaccine is 95% in 2 different cases. So why would you choose AstraZeneca?
I would choose Astra for a number of reasons. So first off, I take manufacturer data with a large grain of salt, as I think we all do. But I do believe that early on, when we talked about the minimal necessary efficacy of the virus, we talked about that 60% number quite a bit. And 60% was the original target for efficacy of the vaccine. And to break it up a little bit, the effectiveness of the Moderna and Pfizer vaccines has been talked about to be greater than 90%. But the efficacy, the true effectiveness, if you will, is likely not to reach those numbers for a number of reasons. The largest being the storage requirements, the extreme cold chain storage requirements, and how that's likely to play out in the real world. But then also an adenovirus-based vaccine is, of course, eminently researched, eminently safe, and has been used for generations. Whereas mRNA vaccines are relatively new and exciting technology, of course, but one that we are still learning about. Let me be clear. I will be first in line to receive any of these vaccines, but I have been following the AstraZeneca vaccine from early on, and believe it's likely that the adenovirus-based vector will lead to more easily spread immunity, more easily uptaken logistics of vaccine distribution.
Rick?
Yes, sir.
Apologies, I'm a mere mortal. Adenovirus versus the mRNA.
Adenovirus is the common cold. And so the AstraZeneca vaccine took the common cold, killed it, and injected some COVID proteins into that vaccine so that it looks like the COVID virus. Whereas the mRNA-based vaccines are new technology. It's a lipid nanoparticle into which COVID RNA has been introduced to code for the spike protein. It's an exciting and new technology that is
very targeted.
Yeah, very targeted, very flexible, and should be able to be produced much more quickly. Unfortunately, these mRNA vaccines require ultra cold chain storage, and that's very difficult.
Actually absurd. Anyway.
I have one observation or question, really.
Yes, sir.
So I'm wondering if unconsciously and with the best of all intentions, we're kind of setting ourselves up for disappointment, because people hear 90% and they think, the jubilation is here and within a couple of months it's all gone. And I know I get a flu shot every year, and every year I get the flu. And the rationale is, well, it would have been much worse if you didn't take the shot, which I call faith-based vaccination. But I'm wondering if the same thing is going to happen, that it's good to have, it's better than certainly nothing. But at the end of the day, it may not be quite as good as it's being portrayed right now. Is it being hyped unnecessarily?
I think it's a reasonable concern, and we don't know the answer to it. We don't know yet whether this will be an annual vaccine or a one-time vaccine. However, there are some fundamental differences between COVID and the flu that suggests, at least to me, that it's unlikely we'll need annual vaccines for COVID. And the reason for that is this, is that flu, A, has a mutating nucleocapsid, just like COVID, of course. Our flu vaccine is directed against the nucleocapsid, and that's why we have to continue to change our flu vaccine. 2 is flu has an avian reservoir, and 3 is flu has a southern reservoir. Those 3 things don't apply to COVID. A, there is no southern reservoir because it's everywhere all the time. B, there is no avian reservoir, unfortunately. And C, the vaccine is targeted against the non-mutating spike protein. So that is at least reassuring to me, but I agree with you that we don't yet know whether this will be a one-time vaccine, a yearly vaccine, or even more frequent.
Thank you.
Hey, if I may, Richard, great talk. May I ask, do you know if there's any research ongoing that is designed to help further stabilize the vaccine so it doesn't need to be kept so cold and perhaps maybe more easily distributed?
Yes, sir. I don't know about the mRNA vaccines, whether they are investigating more stability for them. I believe it's likely. I do know that alternative vaccine vectors, for example, the adenovirus vaccine, don't require those ultra cold chain storage. So while I believe it's likely they're looking for ways to more effectively stabilize the lipid nanoparticle of the mRNA vaccines, I do know that they're focusing also on creating completely different vaccines, just like the adenovirus vaccine, that simply don't require such profound logistics.
Rick, my understanding is the Moderna vaccine does not require the -78.
I believe it's -30 for the Moderna vaccine.
Right, which can be usually is achievable by many freezers.
Yes, sir. And the Moderna vaccine will be
because that's -30 centigrade, which for the people who you put your regular refrigerator at -6, freezer, sorry, or home freezer at -10 or something like that. You're down there.
Yeah, it's pretty cold, and actually we'll be storing it in dry ice. So the dry ice can be changed out every 5 days up to a total of 15 days. And it's our hope that we simply won't be holding on to the vaccine any longer than that because we'll have it in people's arms.
Sounds great. Thank you.
Richard, a small question from me. With receiving packages, say from high-risk areas, say overseas or whatever, actually within the US too. The outside I'm not so worried about, but I was wondering if, for instance, the person that packs it deposited some oil drop, droplets on the inside of the package. What do you think is the risk for that and lifetime for that?
Yeah, I
Say,
think it's a great question. I think I have two answers to this. I have one, which is what is the CDC recommendation? And two, what do I think is the reality? The CDC recommendation is if there is concern for exposure, that is that an individual who was packing that package was known to be infected with COVID-19, to leave it for 24 hours and then wipe it down before coming into interaction with it. I believe that that's overkill. Now, we actually had a scenario like that very recently here in the state, and we dove into the literature to be sure we were making the right recommendations. And again, that goes back to that contact versus droplet transmission. It seems extremely unlikely, especially in a non-porous surface, like a plastic bag, if you will, that COVID would survive for any significant amount of time, particularly in shipping.
I have a question with
Okay, thank
regards
you.
to the vaccine. If, let's say, your first dose is Pfizer vaccine, and considering that there's a Pfizer and a Moderna vaccine, should you be consistent with manufacturers for that second dose, or doesn't that matter, and why?
Unfortunately, you have to be consistent. The Pfizer vaccine requires 2 doses 21 days apart. The Moderna vaccine requires 2 doses 28 days apart. And to be honest with you, I don't know why you have to have the same of the vaccine. One would assume that they're relatively similar. I would venture to guess that there are slight differences in which mRNA they chose to code for which protein and which variation of the spike protein.
And just a quick follow-up to that, certainly you're speaking only for the state of Delaware, but would the public, once this is in wide distribution, be getting guidance as to which manufacturer and who distributes that, so that way they could be consistent?
Yes, sir. So especially within the state of Delaware, we have a system set up to guarantee that patients stay consistent with their dosing.
Okay, thank you very much.
Thank you.
Rick? Question, but wait, there's more. So my wife does a lot of work with Denmark. They just killed 15 million minks because there was a mutation of the COVID-19 that they were afraid wouldn't be respondent to the vaccine. So, but wait, there's more. It will happen again. How do we feel about how responsive we can be to the next round?
Yeah, I think that's the good question. It does seem that is one of the things that drives the desire to have mRNA-based vaccines because of their rapid flexibility. mRNA vaccines hypothetically are completely interchangeable with whatever RNA you choose to encode it with. And I think that has been one of the large drivers behind why mRNA vaccines have been so desirable.
Sorry to interrupt. The mRNA is much faster to be able to deliver?
It's just that it's so interchangeable. You have a shell lipid nanoparticle and you simply inject it with the RNA you choose. And that's it.
Exciting world.
It is.
I have a quick question. Do you, talking about preference for the more traditional vaccine or the experimental mRNA vaccine, do you intend to let the people of Delaware choose which vaccine they get? Or do you know if they're, if clinics plan to have the different varieties? Are they just going to be distributed like what they can get? Like, are we going to have a choice?
Choice will always exist, of course. The AstraZeneca vaccine has not received or even applied for emergency use authorization within the United States as it stands right now. The only 2 vaccines that are in the pathway for EUA are both mRNA-based vaccines, and will be as soon as we get it, we push it out, and as soon as it becomes available, if you want it, you can have it kind of approach. Now, I believe that'll likely change in the months to come as more and more vaccines come online, and that choice will grow.
Based on what you've seen, do you have any particular concerns?
No concerns. So the hypothetical concerns for the mRNA vaccines were that they could trigger a systemic inflammatory response. But very reassuringly, in the phase 3 clinical trials that have been performed, that was not demonstrated.
And have they tested the oldsters yet?
Yes, yes. In fact, individuals greater than the age of 65 made up a disproportionately large amount of individuals within the vaccine trials, which I find to be very reassuring.
Yeah, they're testing somewhere in the order of 15,000 per group, right? Both treated and the placebo. So that's a lot of people.
No, I heard some concern about kids didn't get tested at all, and the oldsters didn't get tested much.
Kids will not be included for quite some time. Just this week, the Moderna trials did begin to include children over the age of 12. So there will be a progressive broadening of vaccine access to lower age groups, but children under the age of 18 will not have access to the vaccine for many months to come.
Can you speak at all to the AZ fiasco, and more important, to the path forward? Because it had very promising results, but it was just really a mess.
Yeah, I'm not well read on the, I know to what you're referring, the clinical trial fall down that they had. I'm not well read enough on it to comment.
Okay, and not cross-examining, just curious.
So Rick, one thing that us and the public are probably wondering about is when you see these case numbers reported on states and county bases, do you believe that those numbers are dramatically underreported? Like the actual number of people carrying the virus is really much higher than we're seeing?
I do. You know, we early on in the pandemic performed serological prevalence studies using point of care devices and found really profound amounts of serological prevalence in high impact areas that outstripped the PCR positivity rate. And a lot of that was driven by lack of access to PCR early on. And I do suspect that there is a large body of asymptomatic carriage, which has driven so much of what has been difficult to get this pandemic under control.
What are we learning from the sewer probes?
Not much. Not much. The sewer thing is a test in search of an indication. Let me tell you.
Right, not real.
Yeah. So wastewater testing has been well correlated with the ability to predict outbreak in certain areas. The problem being is that there's outbreak in all the areas right now, so it's not giving us too much operational information.
Is there hope?
Hope for wastewater?
No, hope.
Oh, there is. We have a light at the end of the tunnel. The cavalry is coming with the vaccine. We have seen in just the past month or so uptake of dexamethasone, bamlanivimab, the Regeneron monoclonal antibody, remdesivir, of course, and all of these therapeutics, which, you know, months ago we simply didn't have. The only treatment I had in March and April in the ICU was a laryngoscope and an endotracheal tube. That's all I had. And to move forward so much, and the clinical picture that I see now is so much reassuring. We're so much more knowledgeable about this virus and the best ways to treat it, that I'll tell you, I will never forget what I saw in March and April, but I don't anticipate I'll ever see it again.
So, okay, so 1984 and George Orwell are not attractive, but how much consideration is being given to using the technical contact tracing now that we've given up on reaching people on phones?
Yeah, so we have about 77,000 in our state who have downloaded the contact tracing app. And
really?
Yeah, pretty good.
No, I didn't even know it was there.
Yeah, about 10% of the population has downloaded it. And about 1 in 5 individuals who are contacted by our contact tracers report that they have the app. And I think as that grows and as more uptake of the application hits, you know, mainstream, we'll be able to leverage technology to help us with our contact tracing.
Can you first now say a little bit more about that, and secondly, raise the profile of that, because I was totally unaware that Delaware is doing it.
Oh yeah, we have a fantastic contact tracing app, which I had a slide on, but I think I deleted it. And it can be downloaded on the App Store on both iPhones and most states now have a Bluetooth-based contact tracing app that is through a partnership between both Google and Apple. They crowdsourced the code or whatever it is, and it is a fantastic tool.
So if we downloaded it, if we enabled it, then we would be part of the circle of folks who, if somebody went toxic, we'd be able to trace back and like go, whoa.
Yep. If you download it and you come into contact with an individual who also has it downloaded, it will alert, and it alerts, very reliably if you spend greater than 15 minutes within 6 feet of another individual.
Well, from what I've heard, I know, Keith, you need to break it off, but from what I've heard, 62% of us are not Trumpsters. And so if we could raise the profile higher amongst us who are not Trumpsters to be aware of it and to do it, because I had no awareness of it whatsoever.
Yeah, highly encourage it.
I'll just say real quick that I live in Pennsylvania and I have the app open right now on my phone. There's 645,000 people in PA who have the app right now.
Wow.
Okay.
There's some base level technology that was installed on all Android and all Apple phones. And then you have to take a second step to go down.
Well, you have to enable.
Right. But, it's the base level app has been there for some number of months.
Right. But you have to deprivacy it. You need to know it's there. You need to say, yes, I want to be part of the world that wants to be careful.
Right. So want to remind the audience, I may not have mentioned it, but Joanne has told me to remind you folks, Rick's presentation was recorded and it will be available on YouTube on the CCN channel. So people can, Rick kind of went through some of the early slides a little bit fast. And if you want to refer back to these slides, you can get it. And now you have Rick's contact information. We are a little bit past the time, but it's been incredibly informative. So thanks to both Rick and Fred for hosting him. And we really appreciate your talk.
Guys, thanks so much for having me. I really appreciate it. I'm going to jump to my 8 o'clock meeting, and I really appreciate it. And please email, text, anything you need to get a hold of me. I'm always available for you.
Great.
Thanks a lot, Rick.
All right, guys. Thanks a bunch. Bye-bye.
You're the man.